All right, there we go. Thank you so much. All right, again, welcome to Innovation Work Group. This is the December 3rd, 2025 meeting, and I'm Kimberly Hendricks, your chair. And I want to first do a roll call. And I think that Robert Young is not going to be here, but just in case. Oh, and then Greg Klauser, good afternoon. And Sally Dershfeld.
Yes, sorry.
Yep. That's okay. That's okay. I thought I'd be kind, and then Sean turned on his camera. So Sean Parkman, welcome.
Hello.
And the rest of you, welcome to the meeting. So first up is those of you that had an opportunity to read the meeting synopsis. Do we have a motion to accept them as presented?
I can make that motion. This was Greg Klauser. I motion we accept the minutes as written and presented.
Thank you, Greg. I have a second.
Second.
Sean, thank you. Any questions or concerns about the meeting synopsis? All in favor of approving the minute synopsis, say aye. Aye.
Aye.
Thank you. All right. Well, first up is Emery, and he's got his camera on. He's ready to go. We're going to do level of payment 2024 data.
Thank you, Chair. Yeah, so we can get started. I guess maybe I'll share.
Yeah, I can pull. Do you want me to pull it up, Emery?
Yeah, if you don't mind.
Yeah, no problem.
Yep. And Maya, if you need to step away for any minute, let me know. I can help with that too. Thank you.
Thank you. Yeah, so we have two presentations today. The first one's something that we've done for a few years. It's reporting on the level of payment. So this is one thing that I think is actually kind of interesting as we go into the renewal season, especially for OWEB, where we take a look at the relative, essentially what the contracted rates, the relativity of the contracted rates are for the different health plans. So we do ask each plan to provide this sort of information. We break it out by different types, categories of service, and we put it together. And since we've done this is part of the performance guarantee reporting guarantees that they provide. We have had it in place for many years. So we do have the ability to kind of go back and take a look at the different levels of payment. And so you can do a comparison from prior years to the current year. We do show 3 years total, but then we do have some slides that show 2 years. So from last year to this year, and this year is 2024 because 2025 is not yet complete. And I think there are some, I don't know if it's interesting, but there are definitely some consistent stories across the data that we'll see. And we did ask the plans to provide a little bit of context around it, but I think we've had conversations about trends going up and costs going up, and I think this presentation will help illustrate some of the reasons why those costs are going up. The reasons behind why the costs are going up, that's part of the conversation, and maybe ties into our second presentation on leveraging purchasing power. But at least hopefully this provides a good lead in to why maybe the second presentation is important and of importance to both OWEB and PEP. But if we move on, let's just keep going. Next slide, please. Yeah, so as I mentioned before, this is part of the annual requirements. And so you can see the service categories there. We do ask them to break it out. Not all breakouts are provided by each plan. Most of it is provided. I think there's some breakouts between, I think for outpatient hospital that we've asked for that isn't quite broken out by different types of service in the outpatient hospital. but generally all this information is going to be shown in the next few slides. So moving on. Yeah, so you can see some of the actual breakouts. As I mentioned, the outpatient hospital, there were Providence. Providence did have, one sec. Okay. Providence did provide a little bit more information from outpatient hospital. MODA and Kaiser did not actually supply the percent of Medicare for outpatient hospital. There's one slide in particular, I think, on medical pharmacy where I'll talk a little bit more about it. I did look into it a little bit, but I think the information that's being provided, generally the outpatient hospital percentages, they're probably pretty close to what they are. But we'll talk about it in a little bit more detail. And then the last one, integrated care management fees. So they are not part of the Kaiser contracts, but these integrated care management fees, if you actually don't know what they are, there's essentially 3 fees that are applied by Kaiser for payments to help manage the care of the members. 2 of them are more fixed costs applied on a per member per month basis. One of them's for medical and one of them's for pharmacy. But Kaiser also applies a separate variable care management fee, which is essentially a percentage of your claims, medical costs, like the allowed amounts, that's tacked on top. So when you're comparing contracted rates, and generally the numbers that you see here, that's not going to be included. We do show it included in one slide to kind of give you an idea of the magnitude of these care management fees on a medical basis. And it does make a bit of a difference when you're trying to compare the different plans. Okay. And please interrupt me as we move on through all of these slides with any questions, comments, or whatever is on your mind. Okay. Moving on to the next slide, please. So one thing we wanted to highlight here is we are trying to be relatively consistent in terms of how we're reporting the data. So we do have color codes for the plans. We do break out OEB and PEB differently. You can see it on the slides, and then we do different types of breakouts for prior year and current year. So hopefully it starts to be easy to pick up as you're reading through this, but I'll try to draw your attention to the actual, the elements, that different data elements that we're showing here. Okay, next slide, please. So this one's kind of like the, I don't know, the big one, the one that's kind of most importance, maybe. It shows the overall reimbursement as a percentage of Medicare. So Medicare, as you know, they set essentially costs based on the type of facility you are, where you are, the type of service, and that's the rate Medicare allows. And so it provides a consistent basis for us to take a look at when we're trying to compare plans. Generally, there might be some differences on where services are done, exempt versus non-exempt, in-state, out-state, those sort of things. And you can have to take that into consideration as you're trying to compare some of these. But overall, since we are talking about 2 entities that are generally in Oregon and are spread out across Oregon, it kind of gives you a relatively consistent basis to compare the different plans. Kaiser is located in the metro area, so they are a little bit different from MODA and Providence. But what you could compare essentially the percent of Medicare between the different plans to see the relative costs of the contracting, or what the contracted rates are. And so as all of you are probably very aware of, Senate Bill 1067 capped payments at 200% of Medicare for certain facilities. And you can see here, generally, most are around that level. MODAs, they're purple on the left, and then for OEB, it's at 189%. And this is for all services, not just Senate Bill, the cap facilities, but overall they're at 189. And then for Kaiser, for OEB, the contracted rates are at 202%. So even prior to considering integrated care management fees, Kaiser is at a higher level in terms of what they're reporting as the allowed amounts for certain services on average compared to MODA. The care management fees, the integrated care management fees that I talked about before, for medical are shown in that striped, diagonal striped up above. So roughly, and this is on average, it ends up making the percent of Medicare about 233%. So that's roughly about 15% additional cost. And so you can see that relative difference in essentially if you had services performed in Kaiser on average versus MODA, what the relative cost would be. For Providence, or for PEB on the right, we have the three plans. So Kaiser, MODA, Kaiser, and Providence. So for MODA, the percent of Medicare is at 178% compared to the 189 for OEB. There is a little bit of difference in that, MODA has just essentially the coordinated care plans for PEB or the Connexus network. So OEB does have essentially the PPO, the wider network. So as a result, probably the percent of Medicare is going to be higher for OEB because they do have that additional network, which is, I guess, less tight. So the contracting may not be nearly as tight, or it's more out of state providers in this case. So that's not surprising that for PEB, it's a little bit lower for MODA compared to OEB. But for Kaiser, you can see for PEB, it's at 201% prior to integrated care management fees. And when you add in those ICMs, Kaiser's about 229%, which is pretty equivalent to the 233 for OEB. And then Providence is at 191. Statewide is a Providence plan. It is blended in. So, and there's probably a few more people outside of Oregon for PEB compared to OEB. And so, as you can, it's not too surprising that Providence's overall percent of Medicare is higher than MODA, and it's kind of equivalent to what MODA is for OEB at 191. So this information is for 2024. I think I'll just pause here. Sally, go ahead.
Yeah, so this shows that cost for services all over, right? Or overall cost for services are higher under Kaiser than MODA. Yes. And from what I understand, Kaiser's not for profit. So why are their costs so much higher?
I think we can ask them that question. I'm not sure I want to put them on the spot right now for that question, but we can definitely take that back. I think this is something that, I don't know, it is something where their contracted rates are a bit high, have been a bit higher. We'll show it on the next slide, historical. They are integrated care management systems, so there's some efficiencies due to that. But I don't know. As we go through some of these other sites, you can see areas where Kaiser might be contracted at a higher rate than MODA, and we can like come up with questions for that, and we can ask those questions, I think, of Kaiser to hopefully address your point.
Okay.
Sean.
Yeah. Sally sort of hits the nail on the head right here. So I have questions, this is an existential question for healthcare right here. Because the theory is that because Kaiser is integrated, because it is designed that way and has been for, decades, that they are supposed to be able to contain their costs more efficiently and provide services more efficiently because they're able to, internalize those costs and increase efficiencies and increase health while decreasing costs. That is the whole shebang. And, that's the entire effort in healthcare, is to try to get systems to be more of a, organized, coordinated system. Kaiser being the most coordinated, at least on paper, and it has the highest cost. That does not add up. That is a problem. And so I would like to know from them, what is the situation? Like, why is it like this? Why is it keeping like this? What is their plan? And like, why is that sort of like promise, like they're sort of supposed to be the healthcare city on the hill, so to speak, and they're like dead last um on cost containment. This requires some questions. And so I would like to hear from them what is the problem? What is the situation? What is their plan going forward? How are they gonna, course correct? Um, because yeah, this is not a great look for the whole system, trying to be coordinated care. So I don't know, like anything that you can help reveal in the next slides. I looked over them. I didn't see anything that was pretty obvious, and I guess I'm looking for some sort of answer from them that's beyond what everyone else can say, which is, well, COVID was really hard, and cost negotiations have been tough, and uh uh it's hard to keep nurses on, and doctors, and people are leaving the system, etc. Like, yeah, everyone's got that problem. So that's not going to be satisfying. I'm going to want to know like what uniquely is happening with Kaiser that essentially has them in a tailspin, because this has been multi years now that they've been heads above uh our other carriers, and it's time to get some answers, I think.
Yeah, we can definitely take those questions back. And you know, we did get some feedback from the plants. And Sean, you said you took a look at it. So, I think it is a very similar story across all of the plants on the increasing costs. But yeah, we can definitely go back with those questions. James, did you want to mention something?
Yeah, I was just going to remind the group, I think Sean is well aware, but his question made me think that we need to remember this is kind of like unit cost. This is like a cost per service relative to a cost per service at Medicare. Then there's the whole discussion of utilization. If you have a higher cost per service, but you keep utilization down, your total could be lower. Then there's a big discussion of admin, which may or may not include the care management fees. But this presentation is not like the risk adjusted total cost of everything, with the best actuarial flavor. This is more cost per thing.
Yeah.
Yep.
And
Good context, and
yeah,
question remains,
yes. Yeah, and one thing that the IWG tried looking into uh, a few years ago was these machine readable files. So these files are files like big files of all the contracted rates that the plans have for the networks, and it's out there for in the idea of transparency, so you can see exactly how much they're charging. The actual true contracted rates are for each type of service at each provider, facility provider, and so on and so forth. We try getting that information. I think it's a lot of data. You were talking, I don't know if it's like gigabytes among gigabytes of data, because you are talking about giant networks. We are exploring to get more information from that. I think there's definitely ways that Mercer can provide it. I have seen some summaries of those files, especially in the Portland area. And in terms of those contracted rates, compared to what we're showing here, they're in line. So it's like even their self-reported contracted rates, I think, are pretty much in line with what we're showing here, where they are generally a bit more expensive than some of the other plants. So the information here, I think, is pretty consistent with other different sources. And I guess to your point, Sean, about this happening over many years. Let's move to the next slide. This is a 3-year look back at the percent of the allowed costs as a percent of Medicare in total. and it's by its 3 different plans. You can see here with the 3 different years. So OEB is the solid color bar, so they are the ones on the left. PEB is the one with the diagonal lines. But I think just kind of highlighting the point about the increases in cost. And these are apps, you can see the percent, the I guess the basis point increases. It's not quite the percentage. The percentages, we'll talk about in a sec, but you can see that Kaiser has been increasing more. Like as a percent of Medicare went for OEB, it went up from 183 to 202% for this year. For PEB, it went from 179 to 201% over the last 2 years. If you analyze that and you just say, what is the unit cost impact on trend? That's 6% per year. So that's roughly in that 6% ballpark. So even irrespective of any utilization differences, population differences, it's 6% additional cost just due to the contracting. For MODA and Province, the increases are smaller. They're still happening as a percent of Medicare. It's about 9 to 10 points as a basis points on Medicare for MODA, and it's 6 for Providence. That translates to about a little bit less than 3%, 2.8% for MODA, 2.5 to 2.8%, and then what Providence is 1.6%. So these cost increases are on top of what Medicare is providing as cost increases as well. So Medicare, it's while the professional services are pretty much flat or maybe dropped a little bit, there still is increases in what facilities get from Medicare. And so that roughly is about 2 to 3%. Let's just say 2%. So if we're talking about this gap to what Medicare is paying, there's an additional 2% that needs to be added to these numbers in the top right box. So really, if you're trying to look at the overall trend, Kaiser's more closer to 8%, MODA's closer to 5 in terms of unit cost, and Providence is 3.5. So it does, those numbers are all above the 3.4% limitation, right? And so this is part of the reason why it's been difficult for OEB and PEB to meet that 3.4% limitation over the last few years. It's the contracting has definitely ended up with higher costs and unit costs. And so there's no room for additional benefits, no room for members, populations maybe, not getting sicker or whatnot, or additional, and there may be additional new services coming in, prescription drugs, the different specialty drugs coming in. Those are not reflected in these additional costs, but this is just purely medical unit cost increases. Sean.
Hey, Marie, so this, trying to put a few pieces together. So what James just said, but as we're looking here, we're really talking about unit costs at this moment with these increases. And unit cost is a bit, as I recall over the years, that unit cost is kind of it's a bit of a euphemism. I mean, it contains a lot of things. It's basically like the cost of a service, of something happening, which can include the costs literally of medical things, like physical objects that are of medical origin, and are expensive this way. They can also include personnel costs, like what I would think of as salaries, but if there's a big increase in how much doctors are being paid, nurses and so on, then that would show up potentially in some of the unit costs depending on the area. Is that correct?
Yes. So in terms of contracting, yes, facilities or providers, systems, or just general providers, if they want to cover more salary, they do have to ask for increases in the contracted rates, and so that would be part of what you're seeing here. Yes.
So sometimes when you hear unit costs, you think about like a car, and it's like that's how much the car costs. But it's like when you think about the car that you're buying, there's a whole bunch of things that went into that car, making that car, that lead to its price, including the health care of the workers, for example, and then like the salary of the workers and so on. And then there's also like the steel and so on. And that's a unit cost from the point of view of healthcare. It's like everything, more or less. But I'm hearing you also say it's not exactly pharmaceutical. This is the part where I always get tripped up. So like, let's say that we're talking about an inpatient. I know you have some slides later, and maybe you can help peel this apart as we go. But let's pretend that you have an inpatient situation. They're in the hospital, and a bunch of things happen in the hospital, right? There's doctors, the doctors are being paid. There's nurses, the nurses are being paid. There's a bunch of physical equipment, such as the IVs and so on, that is also being paid for. And then there's also medicines being administered in that setting, which I sometimes think about as pharmaceutical, but it's not always considered pharmaceutical, right? So there's the drugs, let's just say, and that's not exactly part of unit costs, or it can be depending on in what situation it was. So I guess what I'm saying is, here's my big question: do we have a way of breaking out like what is driving the unit cost increases in any kind of reliable way, such as actually 80% of it is salaries? I have no idea. I made that up. That's not the actual number, but like that's what I'm looking for. Is there any way to get that? Do we already have that? Or would that be nearly impossible because of the way it's all bundled up?
It's going to be different based on which setting you're talking about.
Okay.
I have looked at it in the past. I'm trying to remember what there is a wage basis for DRG facilities, and I want to say it's 40% of the DRG, essentially the base rate, what hospitals get paid. I think it'd be drastically different depending on if you're talking about like a physician, or like ambulatory surgical center, or a behavioral health provider who's just single shingle. So I think it varies. I think there's some reports on that. I don't have numbers off the top of my head, but there's a whole lot that goes into why the contracts or the contract rates are the way they are. But all of those things in terms of internal administration, in terms of wages, in terms of just rent, like rent, right? The facilities, and just making sure, I don't know, like every bit that goes into running, right, a medical practice is going to be essentially needs to be covered by these contracted fees. So there's a whole lot that definitely goes into it. But in terms of details, we can try to look it up and get more information on it. I don't have all the numbers. I don't have the numbers off the top of my head. Sorry. Sally, you had a question. Comment.
Okay, so just if I'm understanding this correctly, what we're seeing is it includes unit cost.
This is essentially, this is unit cost. This is basically, if you went to let's just say, if you went to an office and visit, and they charged, let's say $179 in Kaiser last year or 2 years ago. Now it's $201 because the cost increased. So this is kind of like showing exactly, if you take a look at your EOB and they list out each single service, on average, that the increase over the last 2 years was a certain, 6, 8, well, it's closer to 8, but 6% plus.
Okay, so as we're discussing things, these are just some thoughts I have, conclusions, right, that could be wrong. So correct me if they're wrong. That is one of the reasons why Kaiser shows a higher cost, is because Kaiser isn't just the insurance provider, they're your providers as well, right? So MODA, like, pretend somebody goes to Oregon Medical Group, right? That Oregon Medical Group is paying their doctors, and then the insurance pays a portion of that patient's visit, and the patient has some fees. Whereas if you go to a Kaiser doctor and you have Kaiser is paying that doctor, right, their wages as well as, so there would be a higher cost because of that. Potentially, they're doing both. Does that, am I on the right?
That's a question that I think I can't say yes or no.
Okay.
I don't know.
Yeah.
I think that is a question we can definitely ask of them. There are some other slides later on where it's just like, I think, especially when we start comparing, I think, professional services and what Kaiser charges for those professional services versus what Moda and Providence does. Kaiser is significantly higher. And I don't know if that's because they are, those additional payments are going to salaries or not, or if it's some other thing. But that's a question. I think there's a whole lot of things that go into why a facility contracts or some things contract at the rate that it is. There's leverage in terms of, if it's a single hospital in a location or they have market share, they can definitely use that to get higher rates. If there's more competition, you might see lower rates. I think when I've done some analysis, I think Portland, the metro area, definitely has on average lower rates because there is more competition, I think. So there's a whole lot of things that go into it. I don't know. I can't say for sure that it's your hypothesis is correct, but we can definitely ask that question of Kaiser and explore.
Yeah, thank you. I'm just trying to make sure that I'm not just looking at a graph, but I'm really understanding all of what that graph represents and, all the little things behind it. So thank you.
Yeah, we're just trying to show what the medical services in terms of like an average contracted rate for medical services. If you were comparing the plans, which plan would be cheaper on average? And I think based on this, it does look like Moda's might be a little bit cheaper. Their overall reimbursement, as a percent of Medicare is a little bit lower. And when I've done analysis for PEB, taking a look at efficiencies, I mean, I think Moda does tend to come out best risk adjusted. So, this is, I think, in alignment with that. So part of it may be because their contracting is a little bit better. Okay, any other questions or comments on this slide before we move on? Okay, so one of the things that we noticed, let's move to the next slide. One of the things we noticed, in addition to the reimbursement as a percentage of Medicare going up, was that there's for the non-exempt facilities, it's a little bit, well, I guess for inpatients kind of flat, but outpatient, it's at the 200% level, and we're not seeing any changes. It's basically not just a cap; it's a floor in that case. So we did ask about that. We also asked about the question, I think really, Sean, what you were talking about. It's like, why are the reasons that the rates are going up? And so we did get some feedback from all of the plans. Kaiser's on the slide. I think in terms of the reimbursement, basically staying at 200%, it's like the contracts were brought down and they have remained at that 200% of Medicare because there was a loss to those facilities when Senate Bill 1067 came in. And then I think a lot of this, like similar stories in terms of, COVID, pandemic, inflation, high labor costs. I think Kaiser, they've had some contracting, I don't know, difficulties, issues. I don't know. That's happened. And so that's part of the reasons what they're saying as for the reasons why costs are going up. Sean.
I think it's also just worth mentioning that, we're using 200% of Medicare, so that's the law, but also worth keeping in mind, if I'm not mistaken, and Emery, maybe you have this at your fingertips, but the actual Medicare reimbursement rate has also increased, I think, over recent years beyond the 3.4%, right? So at least
there
this
was
year.
definitely a bump. Yeah.
So I don't know exactly what the numbers were, but I think I saw that it was over 3.4% at least this year. So correct me if I'm wrong on that one, but that's another piece like it's even worse than it because it's going up in relation to that, and that's going up beyond our what we're really allowed. So that was just like one of the weaknesses of the 1067 is like we're hoping that that helps contain us to three as close as we can to 3.4%. But there's a little catch there, which is that if Medicare goes up beyond 3.4%, then there's not much we can do about it. So anyway, that's just also part of the background context here.
Yes, there definitely was a bump in, I can't remember, James, I don't know if you remember, it was like in the hospital market basket increase. I think it was in 20, 22 or 23. I don't know, Margaret, if you remember as well, but I think we did show it in maybe the hospital hospital reporting presentation.
We have it. We can follow up and share those numbers with you, Sean, just, just for information, but it is, publicly available. And you're right, Emery, it was within the past couple of years, there were increases in excess of 3.4%.
Yeah.
On the hospital side.
On the hospital side,
yes. On the hospital side.
Yeah. On the hospital side, there's been increases. If we go to the next slide, is MODA. While the hospital slide, I think they talk about, where is it? Maybe it's, so the first one actually. So on the hospital side, it goes up, but for professional services, that first bullet, there was like payment cuts, or the reimbursement levels for professional was kind of flat. So when we take a look at some of the following slides where we show professional services, you will see some pretty big increases. Some of it's due to Medicare paying a little bit less or holding stuff flat, which is in contrast to the challenges, right, that providers are seeing with COVID and inflations and other stuff like that. So that's part of the reasons that MODA and actually Providence provided for why professional services increased so much as a percent of Medicare. But overall, I think it's just generally costs are increasing. There are definitely reasons that I think are very similar across the board, and the 200% is definitely a floor for outpatient facilities that are subject to the cap. Unfortunately, it's like it's just going to kind of be sitting there for foreseeable future in this case. We can go to the next slide with Providence's feedback. So again, very similar story in that top section and down below. I think it's very similar to what MODA was saying. There has been increases in the percent of in Medicare, that we're talking about, with hospitals increasing above 3.4%. I think it's been closer, a little bit less, closer to 3% in other years, but that's on top of these, percentages we're showing you, which are relative to Medicare allowed amounts. But I think it's been challenging the last 3 years, right, with the renewals, and I think this information kind of shows why. Part of it's been pretty challenging. It's just like the cost of services just keeps going up. Okay. Let's move on to the next section. So we start taking a look at specific cuts of the data. And so we have inpatient, outpatient, hospital, then we get into some of the professional services and other services. But this slide shows two different types of hospitals in payments, in terms of inpatient hospital there on the left and outpatient on the right. So the subject to 1067 are those facilities that are subject to the 200% cap. The exempt are those that aren't subject to the cap. So as you can see here, on inpatient hospital, generally the the amounts are below the 200% cap. We have the next slide shows the year-over-year change. It's been pretty much flat, especially for it's subject to those are subject to the cap. So inpatient hospital really hasn't been a driver of some of the unit cost increases. For exempt hospitals, there's definitely a lot fewer services there compared to the subject is 1067. We do have a bullet down below for Kaiser. The vast majority of the inpatient are at essentially the Kaiser facilities or Salem hospitals, those that are subject to the 1067. So very little on the outpatient or the exempt facilities. More so for Moda and Providence as you get outside of the metro and I-5 corridor. For those for outpatient hospital it's at 200% for those subject to 1067. Province is a little bit lower. But then those exempt, the rural hospitals and out-of-state hospitals, this is basically what facilities have been asking for and getting paid in terms of reimbursement levels. It's a lot higher than 200%. It's like getting 275 essentially. And so, that you do when Senate Bill 1067 came in, you did see a lot of savings with outpatient hospital. But for exempt facilities, they're definitely getting paid more compared to as a percent of Medicare compared to those that are subject to the cap.
So, Emery,
yes.
A couple of points that I don't think to unpack today, but just to kind of put in the hopper. So one, these exempt hospitals, some of which are in state, right? I mean, that
Yes.
also includes out of state. Okay. But so we're primarily talking about rural hospitals like outside the I-5 corridor, essentially. And so there's been some movement. This has been ongoing for the past decade, but it seems to be accelerating this year. There's some hospitals that are on the edge of closing. There have been a couple that have closed, and various other, adjacent medical systems closing. I think Tillamook maybe had a birthing center just closed or something. Maybe it was Coos, can't remember. But in any case, that's happening. And so that's part of the reason why they were exempt, at least in theory. So I think it's just a question. It's a perennial question for us since we're talking about hospitals for a minute. What do we do about that? Because their costs are high and they're going out of business because their costs aren't high enough, apparently. Right? I mean, somehow they're not covering it. And so that leads us back to that question about like, what do you do? What are we going to do about that? Because we have to have coverage, and some of them are closing and they're very expensive. So, so there's that whole topic. So I'm just going to put that over there. And then I'm also, this would not show up in the data in this chart, I don't think. But given the recent fairly dramatic changes to the Medicaid reimbursement system, and the prices related to that, this upcoming year, what has happened, what I think may happen, what I worry about is that we go back to where we were before the Affordable Care Act, essentially, which is that there's a lot of care being done to people who are underinsured, essentially. And then who covers that? It's basically the like insurers like us essentially take on a heavier burden of the costs of facilities, essentially, as they try to absorb that. And so I'm just curious, yeah, for in looking into the future, like how might that, or if there's some anticipation in your rest of book of business about there's no reason why this picture would be better next year, let's say. And just kind of final point on that, can you remind me, I think where this really shows up is in the emergency room, where that kind of cost displacement happens, like, but can you remind me in this chart, like ER visits wouldn't show up in either of these, is that right? Or would it be
No,
lumped into like inpatient hospital?
ER would be considered outpatient hospital, so it would be
Oh,
part of the overall cost there.
okay. That would be outpatient. Okay, okay.
Yeah.
So yeah, that situation may get worse as the number of people in Oregon that are insured goes down, then emergency room costs go up, if that makes sense. So
Yeah, I there is definitely a lot of stuff, being theorized, analyzed on, the impact of the Medicaid cuts. I think part of the conversation, right, with HR1 that PEB at least had, and I think OEP had in the retreat as well. Those sorts of things. We're still, yeah, we're trying to figure it out. I think the charity care element that you're talking about, and those who are uninsured, underinsured, and need to be written off, it is those are services being performed, and it does come to a hit, especially I think in rural areas. So that impact, if it does go up considerably, yeah, I mean it's an upward pressure on these contracted rates. So that's definitely a concern that we're looking into, trying to make sure, and I think there's been board members who've asked about it, so we definitely will be following it and bring back more information in that case. Margaret.
Yeah, thanks, Emery. Just to sort of chime in with one kind of point of context in terms of how I sort of always think of those exempt hospitals. But and there may be opportunities here for us to drill into this more and sort of think about what else to look at. But when I think about them, like they're not a monolith, and depending on what type of hospital they are, Medicare reimburses them differently. So, like for the smaller rural hospitals, Medicare methodology reimburses those hospitals based on their reasonable cost. So they have a formula related to that. For, say, larger exempt hospitals that might be like large DRG facilities out of state, Medicare is going to be reimbursing those under inpatient prospective payment system, where they're prospectively setting a rate that's not sort of directly tied in the same way to the hospital's actual cost reports. So I just kind of want to flag that because I think in that respect, like when we look at exempt hospitals, it's a little bit like there's some apples and oranges going on there. Because even when we're looking at them relative to Medicare, we just have to be mindful that Medicare is using different methodologies to reimburse different types of hospitals in that bucket. So I just kind of call that out. And again, I think there may be opportunities to look a little further into there. As I recall, and this isn't necessarily a super recent number, but my recollection is that about 65-ish% of our utilization is happening at those capped hospitals, which still leaves, about a third that is happening in exempt facilities. So just kind of wanted to chime in with that for some additional context.
Yeah. Thanks, Margaret. Yeah, and some of those questions, some of those price disparities, we will be looking at in the hospital monitoring report, where we'll be looking at exempt versus non-exempt and by like different procedures. So that sort of information, we will try to highlight, I guess, and to show the cost differences. And we do, I think for that, we do show in-state versus out-of-state as well, in terms of some of the costs. We can definitely come back with some breakouts to help illustrate maybe the cost differences. In in-state versus out-state. I think that might have for PET. I mean, there's definitely a greater number of people going out of state, and so there's a definite impact there. The next slide shows hospitals, the payments year over year for inpatient. Not much of a change, a little bit higher for PEB there, where it's a 7-point increase in the percent percent of Medicare allowed. So it went from 167 to 174. Otherwise, all the other plans are pretty much flat, or actually just dropped by a point or so. So not too much of an issue for these facilities and these services. The next slide shows the exempt facilities. You do see bigger increases, but I do caution, there's some definite sample size issues. Kaiser, only 2% of their services are here. So depending on the facility and depending on the type of service, that can make those numbers go a little wonky. So the fact that it went up so much, I wouldn't worry about it. Same thing with Providence. There are more out of state, with Providence facilities in the statewide plan. So we'll dive a little bit more into it, but I wouldn't worry too much about these increases. Next slide. Okay, so the outpatient hospital, I think this is one where we talked about 200% being a cap on the floor. You can see that, it's prior years. This year, it's basically at 200%. The one difference again is Providence, which is about 186, and so it's a little bit lower in this case for outpatient. The next slide, though, shows the exempt facilities. So for Providence, down in the bottom right, it is more of an increase. It goes above, it's now, I think, at 301% of Medicare. The other facilities, Kaiser, I had a big one for OEB in terms of the increases. There's a few more dollars for Kaiser outpatient exempt facilities. I think it's closer to about 14%, I think is what we showed on the other slide. So there's a few more dollars going here. So it's a little bit more of an impact, especially for OEB. But for MODA, the costs are relatively flat. But yeah, once again, we'll reiterate, we are doing the hospital monitoring reports. We're pulling data for that. We will actually get information on percent of Medicare for 24 to do essentially an audit, in that audit to make sure that providers, the plans are paying at below 200%. So that sort of information will be coming up in the next few IWG meetings. So we can dive a little bit more into these various slides.
Emery,
okay.
I have a quick question. Well, I don't know if it's quick. Can't promise that. When this law, when Senate Bill 1067 first came out, we talked about this for a little bit. We talked about Medicare is what we're attaching to,
Mm-hmm.
And it's 200% of it, And I remember this discussion where Medicare sets its price, and it sets its price at a price that it thinks is actually reasonable. Like in other words, they are not intentionally, from their point of view, making hospitals lose money. They think that they're actually reimbursing them at a rate that is market fair.
Mm-hmm.
And yet every hospital, every administrator you talk to, you're like, well, we're losing money hand over fist because Medicare rates are so low and this and that. So what's the deal with that? I know we talked about it once, and I know we're not going to settle it for the United States government right here in this meeting,
Yeah.
but I'm just, from your assessment, we're talking about 300% of a price that Medicare, the government, actually thinks was a fair price at 100, at 1%, and at its base, it's actually that's fair, and we're talking 300% of that. So what are we doing here? What am I missing? They seem really sure that that's a way too low to even just make costs we'll just go out of business, this and that. So is that true? What's your assessment?
Wow. Okay. I don't know. I don't know. I mean, it's kind of like one of those situations where I definitely have a lot of thoughts. I don't know if any of them are really fit for public consumption at this time. But yeah, we've had that conversation, right? What is the right level of pay? And I think we tried to talk about that with the Lodestar, trying to right size payments and what is, an appropriate way of paying members, providers. That's, I think, a question that's probably better fit for our second conversation today. Leveraging purchasing power, because when we're taking a look at what has worked for PEB and OWEB, it's like setting rates kind of has saved money. I mean, OWEB did the reimbursement for setting reimbursement rates for bariatric and I think knee surgeries, right? And then the hospitals came down to that, the 200% cap. And the 200% cap's being copied elsewhere, other states. So, it's obviously seems like it's something that might, has taken hold. So I don't know. I mean, there's a whole lot, and the hour and a half, whatever we have left, is probably not enough time to discuss. But we can definitely have a little bit of that discussion, touch upon it in the second half, I think, Sean. Okay. Next slide. I know we are kind of coming up on time. We'll go through these a little bit quicker. Well, maybe we won't, but I'll try. So professional services are shown on this slide. So these are the reimbursement levels for these different types of providers. So you can see primary care is there on the left. You have specialists, including the therapists there in not behavioral health. That's a different slide, but physical, OT, and ST, speech and occupational. And then you have the surgical, anesthesia, and maternity providers and their reimbursement rates as a percent of Medicare. So you can see the varying levels. And Sally, I don't know if this is where kind of I was like, Kaiser do have their own physicians. They're contracted for Kaiser. And if you take a look at the rates that they're asking for these providers, it is higher than some of the other plans. So I don't know if chicken egg what the reasons are, but it is something that's showing up in the data where Kaiser is definitely charging more or contracted more for a lot of these providers, including the specialists that are doing like surgery and anesthesia compared to some of the others. So this is something that's we've seen. I think the next slide, we start showing prior year over year. So some of the increases. And so as we take a look at this, you kind of have to basically have it because these are on a 200% base in terms of the percent increase. And you also have to take into the fact that, maybe Medicare kind of kept rates the same or dropped them a little bit. But we are talking about, close to double-digit increases for Kaiser. Moda is more like mid-single digits, 3 to 4, 5%. Providence is a little bit higher, I think, closer to 7, 8%. But there are some increases year over year for these services, especially for primary care in this case.
And this again is not just salary compensation this is like a kind of a bundle thing for the services of this type. Is that right?
Yeah. Yes.
Okay.
Yeah.
Although you got to figure salary is a big part of it, but
yes,
it's not 100% what it is, right?
Yeah. So if you go to an office for an office visit, right? So for preventive office visit, it would be, let's just say 212 last year, and now it's 233 under PEB Kaiser. So it's the overall cost for that service for that 15, 20 minutes or whatever you see the provider at. The next slide breaks out another year over year. So this is the specialist PT, OT, ST. The increases are a little bit lower here, but we are kind of in that, low double digit basis point increases. So we are talking 5 to 7% annual increases due to the contracting. The next slide, a little bit bigger for Kaiser. Providence was flat. That's kind of like where they've been. But Kaiser, as a percent of Medicare, it's increasing. These start out at a higher base, so it is still like 6 points, 7% absolute increases. But that's above the 3.4%. Next slide should probably be anesthesia. Yeah, and then so these, as a percentage increase, it is actually bigger for Kaiser. It's the plus 47 points, but that is closer to mid double digits, 13-14% increases. For Moda, it was the other outlier increase for PEP, where it got up to 333. The following slide.
It feels like anesthesia
Yes.
being so heads and above everything else. It feels like there's probably some special follow-up questions for this, right?
Yeah, we definitely asked about that when we started out because anesthesia has been always really, really high. I mean, they do have your life in their hands, right? Where it is a higher stress situation, and I don't know, they can have a little bit more leverage in that. There is some, I think, traveling anesthesiologists that may add to this as well. I think, and that's been the case in the past. James, you raised your hand.
I did a little digging in on anesthesia and ambulance because they're outliers, and they have been outliers, and I think they will continue to be outliers. Even though Medicare is trying to set rates at the cost of providing the services, there's sort of a long-term view that they may have undershot or not accommodated anesthesia and ambulance as fully. In addition, I think both anesthesia and I don't know about ambulance as much, do have a fair amount of contracting leverage. And I think it's a combination of both Medicare not necessarily being quite as good and contracting dynamics.
Okay. Thanks, James. I mean, understood. And it feels like Kaiser's just in a different situation, right? I mean, it's like in order to a magnitude larger increase.
Yeah, we could. I mean I think that is part of the overall question that Sally was asking. Really, I think what are the reasons? Is it because whatever? Give us the reasons why this is happening, and I think we can definitely focus in on this and why there may be an outlier compared to the other plans. Maternity, again, I think very similar story. I get for me for Providence, there was definitely a bigger increase here as a basis point basis and actually as a percentage as well. So a little bit more of a difference there. Let's move on. So this is one area where I think it's an interesting thing where medical pharmacy is where I guess a little bit it's a variant on what you were talking about, Sean, where it's you go into a facility and they provide essentially those high cost drugs. I think for the OED board, Sarah Drake talked about some of the new therapies that are coming out that are multi-million dollars. I think there's definitely been a lot of multi-million dollar ones. I think we're all getting less shocked when we're seeing, oh, this new drug is $3 million for a treatment. It's like it's surprising, but that's kind of like the case. It's like the first time it came out, it's like, oh my gosh. But now it's like, oh yeah, that's another one that's $3 million. And Medicare pays at the average, the average sales price plus 6%. And so they're paying essentially kind of like what you're hearing as these costs. So if you're doubling that, instead of 3 million, it's actually $6 million for that service. So these medical pharmacy, I mean, there is storage and other things, and that's there's that 6% for helping with the storage, but these costs are essentially a commodity that the facility is purchasing at those prices, but then getting charged to OEB and PEB at levels of about 200% or more. I did take a look at some data I had for medical pharmacy for Kaiser and Moda. And while these are the overall facility costs, it's the data I'm looking at kind of paints a similar picture where it's definitely higher than what Providence is charging and closer to that 200% threshold for these services. So basically for that cancer drug, instead of $100,000, it's $200,000. Medicare pays at 100. PEB OEB is paying at 200,000. So that is definitely an area where I'm just seeing kind of like some costs above where it's a commodity that PEB and OEB is paying more. The essentially list prices. And then there on the bottom right, the office position. I think, again, it's an area where Kaiser does kind of stand out as a higher reimbursement. We are talking like what 40% more, it's one and a half times the price versus what Moda and Providence is paying, which is closer to one and a quarter. So there is some potential, I guess, cost differences there. And we are talking about $10-15 million a year in services for medical pharmacy in the office position. So we're not talking small dollars in terms of the impact here. Next slide. So this is a comparison to prior in the office. That's kind of been consistent. I think Providence actually had a little bit of a drop, but it's been pretty consistent in terms of the levels as a percentage of Medicare. Okay, next. So laboratory and radiology. So lab and radiology, we show here, again, the discrepancy for Moda and Kaiser, that is just their inpatient versus subject to 1067 versus exempt based on the overall reimbursement level as a percentage of Medicare. So it's not specific just to lab and radiology in that case. But then office and physician, it's generally, I think, lower for lab services for Moda and Providence. And then you can see Moda is definitely, Kaiser's definitely a bit higher in this case, or a lot higher. And then it's a similar story for radiology and imaging, where Kaiser is contract rates are higher than in Providence have. Interestingly, the independent facilities on lab services, Kaiser is actually 100% of Medicare, but in office physician setting, it's 2.5 times. Next slide. Okay, so this is the year-over-year comparison. I don't think there's really, we talked about it and we're over time. So you can peruse this at your own leisure. Let's move on. And then I think this will be the last slide I'll go through, or last section, behavioral health. So independent facilities, those are essentially, behavioral health facilities. You can look into why Kaiser is at 230%. There usually aren't many services or many, much utilization for independent facilities for like residential facilities here. So that's not as, big of an issue. In terms of the office, and these are the therapists, in terms of the payments, you can see it's about that 120, 130% level percent of Medicare. It has, I think, let's go to the next slide. I think we have the year-over-year changes on the next slide. Yeah, so we have the changes for Kaiser actually dropped a little bit as a percent of Medicare. For Moda, it's increasing, and then Providence dropped a little bit and about 120. So, behavioral health, I think there was a push in Oregon to bump it up, especially with the directed payments. That's kind of taken place, I think, not last year, but the year before. But one thing to note, with this Washington State bill limiting payments to 200% of Medicare for their employees and school teachers, they did provide a floor of 100%, 150% of Medicare for behavioral health providers for those plans. So at 150%, obviously, it would be an increase compared to what OEB and PEP's currently paying. And I don't know if there's going to be any issues, especially in the Vancouver area, Portland area. But that is something we're going to monitor and just make sure there's no erosion of networks, or people just want to take members that are in Washington versus Oregon. So next, the rest of the slides. This is ASC. I think this is comparison to prior. For Kaiser, the ASCs are definitely higher. For MODA, they're lower, and Providence is lower. And year over year, they actually decreased. We'll take a little bit more of a look into this on the hospital monitoring report. So more to come. Next slide. And then this one, James's point on ambulance transportation there on the left. Kaiser obviously is in the metropolitan area, so that might have an impact on why their ambulance is lower, because it's just easier. It's not rural, and you don't have as many air ambulance costs. DME, that's a commodity, right? You're buying something and you're selling it, or giving it, providing it to a member. That's just like a fixed object. And it's interesting that it's like about 100%. So Medicare is paying it appropriately, and then the rest is just kind of like an all other catch-all category. And then these are just additional comparisons. You can take a look at it, but it's just repackaging the information that we showed before. And I know I ran a little bit long. Lots of good questions, comments. I don't know if there's anything in terms of final thoughts before we take a break. Ollie?
Yeah, I just want to thank the IWG for the comments and feedback. We're taking this analysis along with the next report, developing some potential legislative concepts, for consideration of the boards to endorse going into the 27 session. So, there's obviously a lot of opportunities, and we'll see what kind of appetite there is out there, but there's no shortage of opportunities. So thank you.
Thanks. And
Yeah,
I don't want to
Emery.
Go ahead.
Oh yeah, I just want to acknowledge we had some great discussion and great questions. So we will definitely be following up on the work plan for the work group to ensure that in subsequent meetings we are coming back to address some of the questions that were raised, or to dig deeper, begin to get into it.
So I'll turn it back over to you, Chair.
All right, so I think we're going to take a break, and it looks like we scheduled a 10-minute break, which I love. You guys all know that I got to go through 3 logs to get to a restroom here at the prison. But anyway, I will beat feet and make it fast. So we're at 2:44. So let's get back at, I'm going to add let's go 2:55. How about that, you guys? And I'll see you back, and I'll put it in the chat. Thank you.
I just put it in there for you, Kimberly. So take your break.
Thank you.
You bet.
I appreciate you thinking.
Yeah, I learned that. I'm like,
I don't know. I'm just gonna go and do that. And I found
I'm going to the Silverton Christmas market tonight. I'm so excited. It's supposed to be a lot of fun.
Fun. Are you taking grandkids
No,
with
I'm
you?
not taking the babies. I am
Okay.
taking
It's
my
a
little
grown-up outing.
sister. Yes, my
Nice.
retired little sister and I are going to go, and we will sit in Santa's lap and we'll get pictures and we're going to do the thing. And I said the only qualification is that no babies. I have babies all the
Yeah.
time, and I wanted to just
Yeah.
go enjoy the lights. And
Yeah.
it's the only night where no rain. We've got rain coming now
Yeah.
forever. So
Good timing.
yes,
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 and I agree. Enjoy. It is great to celebrate with the kids, and it is also
yep.
great to celebrate with the
Oh yeah.
adults.
Oh yeah.
Yes.
I mean, every weekend I got a house full of babies. I love my babies, but I'm going to
Yeah.
do something on my own tonight with my little sister. So it looks like we're
Fun.
ready. Mercer's up
Adults need
again.
their vacation too, Kimberly.
Exactly, right? We do. And I seriously, I felt so guilty saying I didn't want to bring any babies, but I love my babies. All right. Okay, we're going to get started. And next up is leveraging purchase power. I love it. Part 1.
Yes, part 1. Ollie, go ahead.
Yeah, I just wanted to jump in. You all might remember the governor's office sent a joint letter to the PEB and OEB boards about late last spring. They're very interested in working with the IWG on cost containment measures, and I think they're looking at this presentation as kind of being the first part of that, and then probably engaging with the IWG in early spring. So this is kind of just teeing up this conversation and looking again for opportunities for cost containment measures and obviously quality as well. Thank you.
Wonderful. Thank you.
Yeah, thanks for that lead in, Ollie. Yeah, it's I don't know if the first presentation maybe fired you up and you have some ideas, but it is leveraging purchasing power. It is, just trying to find ways to save money, to improve quality, make member experience better, that OEB and PEB can kind of like work together. I think there's some definite potential for some big ideas, some smaller ideas. We're going to go through the presentation. Maya, actually, why don't you go to the next slide, where we'll go through and talk a little bit about, what to think about, what might constitute using this leverage, use of leverage. What can you do? What can you need to think about in order to make it successful? And we will also show some state examples, including Oregon, where it's like kind of give some ideas, at least, provide some examples of where actually has been helping, and hopefully that will spark some thoughts, some conversations, because this is one of many. I mean, essentially we are kind of talking about, I don't know, it's not just purchasing power. I mean, an RFP is purchasing power, and that's definitely one way of doing it, but there's also other ways of doing it, and we'll go through that, and hopefully we'll have some good discussion and have some topics, some thoughts for the follow presentations in this case. But let's move on to the next slide. Thank you. So this was kind of like just what Ali had mentioned. There was a letter, and we're trying to start the conversation here. So this is one of many. Let's move on to the next section. Or next page, yeah. So what is the purchasing power of OEB at PEB? There is definitely there's a big size. It's over 300,000 members. So it's huge. It's also, very let's say politically well known. I don't know. There's some political influence, obviously, with it, with OEB and PEB. With the legislature, there's bills that impact OEB and PEB that do have impacts on the rest of the state. So there's a lot of the governor's interested, that's obviously helpful. There's, Rep. Nose is on the representative board. So there's definitely some way, there's some influence that OAB and PEB have, and the different unions that are constitute OAB and PEB. But, there are challenges, and they're on the right. I think the health systems, there's a little bit more flexibility, I think, in the Portland metro area because there are multiple health systems. But once you start getting out of the Portland area, it's like it's essentially single health system, single, facilities, hospitals elsewhere. And so that system concentration, we talked, and I think James talked about it, and we talked about it, where they get a little bit more leverage in that case. It's hard to implement things if you're the only game in town, right? And so that's a constraint. The market, is complex. The way healthcare is complex. I mean, we talked about what really constitutes price. I think, as we talk about what constitutes quality, what constitutes the needs of the members, that's definitely complex and stuff that we need to consider as we think about ways to leverage the purchasing power. The third one, I think, is one that we've kind of come into with IWG, especially with the COEs. When you talk about trying to save money and improve care, I think everyone goes, yeah, that's great. But then you start bringing in, well, the member may have to travel, or the member may have to take it upon themselves to change their behaviors. And that's where we start running into challenges. There's been a lot of consideration about, trying not to make it too onerous for the members. And that was one of the big challenges around the COEs, especially, potentially asking them to travel to get to a better provider. And that balancing act is something that the boards, the board members need to consider, and the staff needs to consider, and us, the consultants, need to consider as we are bringing in these ideas and thoughts. And so that is a challenge, and has been a constraint. It has, I don't know, maybe in some cases it's like caused things to be implemented a little bit later than it may could have been, and could have saved a little bit more money earlier on. But it's something that definitely needs to be considered as we move on, because it is a concern of all the board members. And if it's too onerous on the members, it's not going to be accepted. And then the last one, the carriers, it's basically the rates are what the carriers have, except for outpatient facilities, outpatient, facilities subject to Senate Bill 1067. I mean, those are capped at 200%, but the other rates aren't too drastically different from if they're not exactly the same to what they offer to other clients. So that's a constraint. It's like, will you be able to find a carrier that's actually going to create something custom for OAB and PEB? And would they want to do that? That is a concern question. James, I don't know if there's anything that you want to add to this.
Well, I think that this scale balancing slide is good. And I think the question is, if we are trying to throw our weight around on the left, it doesn't look that big. 8% of the state population isn't a substantial minority. And on the right, really, it's the carriers who are throwing their weight around to try and get the best rates for us, their client. So I think we either might want to think about partnering with other buyers to get that 8% up. I don't know if it's government buyers or industry. And then we might want to think about creative use with the carriers of somehow chipping away to get maybe a little more custom representation for our admittedly large but not majority population. So I think this is the crux of it. We would like to use our leverage better. It's as big as it is, and we're going through other entities.
Yeah, and I think our next section where we start talking about ways to think about and to issues to to think about, to concern yourself about. It does bring in a lot of these things where it's like, okay, so what's the best way of trying to achieve what we're trying to achieve, and what are the design elements that we need to do in order to make it more impactful or more likely to be accepted. And so, those are, I think, the specifics are more further conversations, but at least bringing up and thinking about, those thoughts and starting to think about, potential ideas is hopefully we spark something in this conversation. But that's our goal for this meeting. Okay, next slide. One more. Okay, so kind of to me, the question is, it's like you're trying to achieve something, right? So we need to define what we're trying to achieve. I think entire system reform, which is, I guess, kind of where Sean was going with his initial question about like healthcare in America. It's a huge thing, and it's like, are we going to be able to do it? We tried kind of getting to it with Lodestar. I think it's like it was maybe it was pretty big idea. It's and but it's it was an idea, but we trying to get better idea of what we're trying to achieve, and maybe being a little bit more targeted, as James said, might be one way to think about it. But it's like it is something that we need to concern ourselves. It's like, okay, so what exactly are we trying to do? Are we just trying to save money? Are we trying, payment changes? Are we trying to change how members interact with providers? Garner was definitely one way of doing that. Do we try to do other things with that? COEs. And then, it's like the other aspect down in the bottom right, the provider delivery system. That was a little bit with the COEs as well. There's other states that have done stuff with provider delivery in terms of trying to improve quality. I don't know if there's like, value-based payments would fall under that. All of that stuff is to really improve quality and lower costs, right? And so kind of defining specifying what we're trying to achieve, I think is necessary. And the questions to think about as we go through that process are there on the left. So how are we going to do it? The mechanisms. How easy is it? Is it understandable? Is it something that people can relate to? Or is it something that's too big, too complex for people to bring in all of the interested parties to be on board with it? That's also tied into the acceptance of the change, right? If you're asking people to basically, you can ask people to take less money, they probably won't accept it. I guess the legislature forced these hospitals to take less money with 200% Medicare. The acceptance, I guess they had to accept it, but they weren't happy about it. So what can OEP and PEP do? What can IWG? What's the idea that we're bringing, and can we get that change accepted in this case? And then the last one is like the time frame. It's like the time frame is dependent upon how it's being implemented, and how how many people it's impacting, but it is something that needs to be considered. I mean, the issues with OEP and PEP, right, with the renewals, they're right now. We're seeing big increases, and we have a 3.4% limitation. Unfortunately, we're probably not going to have too many ideas from IWG here that's going to be able to be implemented for 2026, 27. But keeping that in mind on the types of things that we want to talk about, types of things that might be achievable, and getting that quicker, those we need to think about all the other elements in order to make the change maybe happen faster than years down the line. Just pausing here. Any thoughts? James, I don't know if there's anything you want to add.
Not really. I guess it seems to me that this sort of leads towards something you might be talking about more about, whether we try to have like a market-based solution, or whether we rely more on regulations and legislative solutions, or maybe some combination of both, where there'd be some kind of a legislated target or budget, or something. And underneath that, there would be try to change the incentives without disadvantaging the members too much, to try and find the inefficiencies or the inequities. A lot of these topics, Sean, kind of come back to 20-year-old ideas or areas of interest around site-dependent costs. And there are hugely varying costs based on where you get your care. Ambulatory surgical centers versus offices versus infusion centers versus outpatient hospital. So I guess I think somewhere in here, we need to either try to find a cool use of market incentives and the members voting with their feet and finding better high quality care without making them feel put upon, or we can try to have a more of a top down like 1067. And then somewhere, as I say those two things, for some reason, the third idea that comes to my mind is to chip away at some of the bigger chunks of healthcare that might have these inefficiencies and find the reference price that would work and offer to pay it, and see if we could encourage some providers to accept that cost. When Emory goes through the state examples, you'll see more about what other folks are doing.
Yes, Sean.
So I had a couple thoughts. Would you rather wait?
No, yeah, go for it.
So none of these are totally fresh in that you've heard them before, but since we have the question, and some attention from the governor's office, take a swing. If it lands, great. If it doesn't, it's just an idea. So we've talked about this. James, you can just talk me right off the stage, feel free. But we've talked about rural hospitals. And so not that rural hospitals are like the cornerstone problem that we're trying to solve or something, but it's a piece of the puzzle. Their costs are higher and so on. So the idea would be this. This would require, because I'm hearing the governor, like coordination, collaboration, and I'm also hearing James that 8%, we would have to like think about how to partner with a larger group than just us. So this would be legislation for sure, because it would require some, things to fall in place. But the idea would be that you take the rural hospitals, the one that, the exempt hospitals from our point of view, and you basically turn them into utilities. They're like, we go in together with some other groups to basically pay for those hospitals to get, collectively. And instead of paying for a service, like, oh, I had one person that, gave birth in that hospital, so therefore they get reimbursed blank. Instead, all, OEB, PEB, and whoever else we partner with are all agreeing that we're going to pay for these hospitals at a certain rate. Just everyone, the doctors get a salary. It's not based on usage. It's just based on basic services for the hospital. And, these hospitals would not be for like hip replacements and stuff like that. It's just basic services, maternity care, that kind of thing. And then, so then the price would be, established like you would a utility, like we do all the other utilities. It's like every year, it's like, well, cost went up like this. So, there would be a committee somewhere, probably some of us would be on it, that just kind of like, allows cost to increase by a certain amount based on market forces, but otherwise, no, it's regulated. And then those hospitals, so that would have the benefit that those hospitals are stabilized. So we stop losing rural hospitals. The providers might like it because they have sort of they're not chasing procedures. They're just salaried, getting a fair wage, a fair payment. lower reimbursement, or sorry, documentation, all the paperwork and whatever could be simplified. Members wouldn't notice, frankly. So there wouldn't be any pushback there because it's like same hospital. It's just on the back end how the paperwork's happening. So you wouldn't have that. The real trouble would be, it's complicated legislatively a little bit, and then we'd have to figure out some partners to do this with and establish a mechanism for figuring out what the price is for the hospitals. But essentially, we're all doing that anyway. Like we're all kind of holding up those with Medicaid and Medicare, we're kind of doing it together. It's just that we're not doing it coordinated. And so the hospitals are kind of spinning. So that's just one idea. James y'all can just talk me out of that real fast if you like, but just throwing stuff out there. It's an idea. I think for the other things, this reference-based pricing, I have to say, I admit I was a bit skeptical when 1060, when the bill passed initially, of like whether that would work or they would just work around it. So I've been pleasantly surprised, and I'm perfectly willing to admit that I was wrong on that. That kind of worked longer than I thought. So that makes me more interested in other types of reference-based pricing because it's like I'll be darned if that didn't work, to some degree, right? So that's interesting. I don't have more thoughts on that. I was just, that would be something for us to dig into. Like, what would the next thing be that we want to find a reasonable reference-based price for? And then can we just pursue that, So I've been surprised by the success of that, and I'm game for it actually. So there's that. And then there's the big one, which is how we pay for stuff in general, which we've been talking about for a long time. And maybe it's just it's just something on the horizon that no matter how fast you run towards it, you just never get closer to it. But alternative based payments models, it sure seems like the way that we pay for stuff is entrenched and not particularly healthy. Just the way the market works or doesn't. So like if you're really gonna swing at the whole thing, and I think we're probably getting to some crisis point, if not in Oregon, just in the US at some point in the next, I don't know, 8 years, where we just have to try something else because it's sort of going to collapse on itself. Then we got to kind of swing at the main thing, which is like how you pay for stuff. And right now we pay for we pay for sick care. That's what we do. One episode at a time. I see Tennessee's example in your slides there. That's like maybe. Like at least they bundle them together, and it's like that's slightly in the direction, right? It's just like we've all really taken a swing at transparency. Various states have. I don't know if one that has actually been successful in price transparency, or just like you actually know what the thing costs. But there's all these things about how you pay that are just so dysfunctional in the current system that it's like, can you poke at some of them, such as bundling stuff together and just be like, look, I'm paying for a a pregnancy and birth, like that's a thing, and so this is what it costs, or whatever, or just totally different alternative payment model that we pay for health outcomes rather than like discrete incidents. I don't know, but that feels like the big conversation somehow to just fundamentally change the way we pay for stuff. So those are 3 things. I don't know. Just throwing it out there.
Yeah. Thanks, Sean. I think your first one was not an idea I had thought about in the context of OEB and PEB, but it's definitely an interesting one. I think we had James was talking about. We were talking about different places, like he brought up Germany, and it's like just different types of healthcare systems, and whether what makes them potentially more successful, or what elements can be drawn from that. I think that kind of falls in line a little bit with your first suggestion, which is more of a much more transformative way of changing healthcare. It's making it more, yeah, like you said, public good, right? Versus more like privately owned in this case. And so
For the
that is
rural
definitely that.
hospitals.
What
So I'm
rural
not taking a
hospitals?
swing at the hospital association. I'm just saying, for the rural hospitals, that's all I'm
Yeah.
saying.
Yeah. I mean, I think a lot of it, it's like, I mean, I guess in some ways we are kind of taking a swing at the hospital association if we talk about reducing payments in any way. There are definitely a lot of different stakeholders in terms of, their interests, right? Everyone's trying to protect what they currently have, expand it. And it's just whether that can continue is not. I mean, it's like right now, at least for OEB and PEP, it can't continue, right? We can't keep having rates increase by just the underlying cost of services increase by like 5-8% per year when we're limited to 3.4%, because that delta, that difference is on the member. And there's just no way to find marginal savings that's just going to be able to make that big of an impact. And that's kind of like to Sally's comment, right? It's just like we're faced with potentially huge changes if we have to cut another 5% or whatever, or like 5% in actuarial values, cost sharing. That's just like, that's scary, right? And so we don't want to have that. But that is kind of getting to the situation that we're faced with. So, but your other thoughts, I mean, I think, yeah, I mean, those types of conversations, I think, especially like the reference-based pricing, like I mentioned earlier, the states, and maybe Maya, actually, let's go to the state examples, especially in the interest of time. And because it kind of does bring in some of the thought processes as we get through them. Um, one more, let's go to the Oregon one, right? Let's start out with, so we did, this is what you're talking about, Sean, with the, reference-based pricing. And also I brought up earlier the reference-based rates for OEB. It's like in the case of Senate Bill 1067, it was the legislature that applied it. And that's one of the possibilities that you're talking about. Like going to the legislature saying, hey, we're not going to pay this much. Ali talked about, legislative concepts in which are kind of along those lines, right? Where can you get that leverage? What's a change mechanism, right? Statutory intervention here. And what are we trying to change? What they get paid, and that's relatively easy to understand. It's so easy that other states are replicating it. It's so easy that, it's like, we're not going to pay more than this. That's a very easy thing to say. It doesn't take into fact that, whether quality's considered, it doesn't take into access, but it's like, we're just not going to pay more than this. And that is a concept that's, you know, like I said, easy to understand, relatively easy to implement, and it's like been successful, and it's apparently successful for other states as well. So that is, one possible type of intervention. James had talked about like a little bit more targeted. You had talked about certain things. I brought up medical pharmacy, just like areas where it's kind of like, why are it's the payments at this level? Should they be at this level? And what can you choose? Is there a little bit more of a commodity? I think, James, you were talking about some, I mean, and like preference sensitive, right? Or potentially those little colonoscopies, I think, has been a common one, right? Like, what's the right price for a colonoscopy? Everyone can pretty much do it, right? And so there should be a little bit more, or labs, like it's like, what is the right price for that? And is there a way to basically say this is how much we're going to pay? James, you came out.
Well, Emery, you use the word commodity for different parts of healthcare, and I think that has been quite compelling to me. If there's a little vial of a liquid that's going to get injected and it costs $1,000 on this side, why does it cost $3,000 on that side? And, we saw DME, durable medical equipment. I mean, it seems to be that, adult diapers and nutritional formulas and things, it's a competitive market. They buy it, they resell it. It's not 200, 300, 400% of Medicare. And I guess I think one idea would be to chip away at things that are relatively common, relatively commodity, and have a high variation in payment across different sites or modalities. And we could put colonoscopies and MRIs and these medically administered drugs. I think really this is not a small cost category, and it is kind of like a thing, and you can buy it. And I think trying to come up with I'm Sean, compared to some of the big policy reform ideas we've thrown around for years, I'm thinking that maybe chipping away at some easy ones that are not insignificant, but don't require us to reinvent healthcare.
Yeah.
I also do like your idea about rural hospitals. I think that would be better as a statewide, but I've seen some good projects where they kind of call it a global budget, but it's really more of a regional hospital only budget, and they try to make sure there's enough money. And it changes the way the funding goes to those important challenged rural hospitals. Anyway,
Yeah, I like where you're going with that, James, with the commodity discussion. I mean, it's interesting.
And I think it's also something that is pretty flat, pretty easy to understand. It's
Yes.
the kind of thing that it becomes more egregious because it's so simple. And
Yes.
it might be the kind of thing that legislators would like to say, that's not okay. We can't be doing it. I think the challenge we really face is finding a way that someone might want to accept less money is not easy. If we only have $100 and we say, sorry, I've got 100, do you want to take, do you want some or not? Many times I think people say, oh yeah, that'll be fine. But in the absence where there is no limit, there is no maximum, more is better and worse for us.
Yeah, and just to be clear, I'm not suggesting on the first idea with the rural hospital thing that OEB and PEB would do that alone. That would be a legislation thing, and it would have to be kind of a statewide thing. We would need a lot of partners. That we would just be a few interests in a larger thing. So that's a bigger. That would have to be like an idea with its own legs. Like that can't be like PEB and OEB's idea. We can. I think what I'm hearing is that there's a question from leadership that's just sort of like, do you have any ideas? So in the spirit of that is all I'm saying is just like, well, here's an idea. It would require someone else to run with it. But yeah, we definitely could not do that alone for sure. Just to be absolutely clear about that. And then, but yeah, I like this idea of, because the fact is, we do apparently, supposedly have like a free market system for the purposes of healthcare, but it just doesn't work that way. It's not a functioning system, free market, because the price is not clear, which is one of the things you need in a free market competitive system. And you need real choice, you know, and those things are not true. And so it's a dysfunctional market. And so I really like what you're saying, James. Like, you could just take a little piece of it and just make it a little more to function more like an actual fully functioning free market. Because you just like you would know what the thing costs, and everyone can see that the two places have very different prices for the same thing, and it's like, yeah, it's interesting.
Yeah, so Sean, I think it's the next one's Minnesota. Actually, let's go to the Colorado one because I want to kind of build off of this. This is a little bit like Garner, except it's different in that it's cash payments, but it kind of the member has to look up the price, right? Or look up the service, look at the price, and they get dollars back if they go to certain facilities providers that are cheaper, um, or there's some quality in there as well. And I think that's kind of along the lines of what you were talking about there. I think, like, is there transparency in the price and getting that information out to the member? I think that's definitely valuable. I think, but it is putting the onus on the member. And there is a little bit more of a difficulty in the uptake, requiring that of the member, how much it's who's going to put the effort in it. Some people put more effort than others, but not everyone's going to do the effort, I think. um, and whether it's some sort of dictation of this is what we're going to pay versus you go find a place that doesn't pay as much. It there is that balance. It's like what's going to be the most impact, easiest to for the member to really get the benefit, reap the benefit, or at least understand it. And in many cases, it's like if it's not on the member, right? It's just like behind the scenes, and that potentially could be more impactful in this case. We've run into the issues with the COEs, right? Asking the member, it's like, okay, we're going to give you a list of really good low cost providers, but then the issue is like, well, we're gonna, you're asking a member to change where they're going in their care pathway, and that becomes something that becomes a sticking point. And so I think I'm not saying that's completely bad, but I think it does become a roadblock in terms of that we need to consider, right? It's the means of increasing acceptance and also the complexity of concept. It's like, is it going to be too much? And we need to keep that in mind. So, but in terms of reference-based pricing and setting rates, I mean, that's kind of like, I think we've been kind of more than kind of just obliquely talking about it. We've been kind of, but that has been shown examples of that. And we've asked, I don't know, Margaret, and we talked briefly about trying to get information from Colorado on this, and maybe if like the uptake on Garner so far, if there's any details on that, to kind of see how that that process has been.
Yeah. So yeah, we have talked to Colorado. I don't have any data from them yet, but anticipate they are going to be sharing kind of what updates they have on experience with their program. In terms of Garner, so far, OEB just went live with that program October 1st, so we really don't have any information in terms of claims payouts or anything like that as of yet. I do know for OEB, and I have to look back at the most recent numbers. For OEB, I think we had close to 20% of members that had already signed up. It was in the high teens. For PEB, we're lower than that. I want to say most recently we were around 5 to 6% of eligible members have enrolled, but the PEB plan year hasn't started yet. So I think we anticipate that really we're going to start to see more uptake and engagement once the benefit plan year starts. And I would generally expect that we'll need to be at least, 3 to 6 months into the plan year before we can start to say anything about actual claims activity in terms of members choosing Garner providers. That'll take some time just because, not everyone goes in for care at the first of the year. And there is a billing lag and then a processing time frame for Garner to process the claims they receive and provide reimbursement to members. So all of that said, I think things are on track, but it's just a little early yet to share a lot in terms of concrete information as of yet.
Yeah, it'll be great to see if there's a little bit more information, especially in the next meeting, kind of trying to just understand, the appetite for members, to take up something where you can get essentially $1,000 off of or whatever the HRA reimbursement ends up being, right, off of your healthcare costs. And, what's the effort level that members are willing to take in order to achieve that, and what percentage of members? It's like if it is greatly successful, there's, we could definitely go along a little bit more of the lines of a member focused solution. But in many cases, if it doesn't take, then it might have to be a top down, we're going to force it kind of approach in order to achieve that sort of savings. But be definitely be interesting to find out and to help guide our conversations. One other way, and if we go up one slide, Maya, to Minnesota, another way of kind of the other way. Thanks. Another way of potentially kind of doing a Garner type, I don't know if it's very COE, I don't know. It's a combination of cost and quality in terms of segmenting providers and then making the member kind of select the type of provider in order based on their cost and quality. And if you select a higher quality provider and that's lower cost, you get better cost sharing, is what Minnesota does. So basically, instead of having an app, to look up these providers, they have a tiered network system. So basically, that you have different tiers in terms of cost sharing. So the highest tier in terms of cost and quality has the lowest cost sharing. And then you find out the list of providers that are considered high quality, low cost, and that's, if you go see them, that's your you end up with the best cost share. And then
That's
the
almost
second
like
level,
COE, isn't it?
it's a little bit like COEs, yeah, a little bit like
I mean,
COEs. It's
I'm just remembering to our experience with that.
Yeah.
And how we basically spent like 2 years trying to figure out how to do quality, but that was a heck of a thing, right?
Yeah.
So the devil's in the details there. Like how would you, like, cost is maybe one thing. Even that's kind of difficult because you got to bundle stuff. Otherwise they'll just around whatever it is that you're saying, or whatever it is that you're paying for. They'll be like, yeah, but there was this extra thing that. So you got to bundle it. That's hard. But the quality thing was crazy. That was super hard, right? So how did they
Yeah.
do it?
Oh, so Minnesota.
Mm-hmm.
Yeah. So I think they hired. I think James, you have the details on the cost and quality. I mean, because it's not just it's more than just bundles, correct?
As I understand it, there's sort of an episode concept. I think that quality is a little bit more of a pass fail or a gate and less of a real driver. So I think, Sean, you're right. When we were trying to do the COE, the nuance of quality became a bugaboo to get through it. I think both Colorado and Minnesota, they do have quality, and if your quality doesn't come out good, you can't be in the top tier. If you have good quality and you want to lower your contract prices, you can get into the top tier ASAP. I think all these quality measures, at least all the ones I've worked on, they're all a work in progress. None of them are all that perfect. You have a couple different metrics. You hope that that's close enough. The Tennessee example that we were going to talk about, there's an episode, there's a couple metrics per episode, but we all know that, it's hard to measure the quality of healthcare in two standardly reported statistics that happen to exist on claims data. So, yeah, I don't think that's a good answer, but I guess I think having quality be a barrier, like a less complicated entry point.
I
You
see
have
that.
to have pretty good quality. Now let's talk about price, which is a
Right.
little less abstract.
Okay. I can see that.
Yeah.
Yeah.
And Dr. Mary Kay, I think in the past had said something that stuck with me. It's like you want to get rid of the 10% that are at the bottom, right? You want to get rid of the bad providers. And once you have that minimum threshold, maybe we start talking about, the cost differences there. And that could be an approach instead of like going top down, we go bottom up. And in terms of like, that changes the COEs. It's like we don't really talk about like who's the best quality. We just, like don't have the lowest quality in the network, and we have everyone who's willing to accept the contract terms be part of it. That sort of thing, that sort of approach might be easier for people. I in one of the prior slides I had quality is a little bit more nebulous, but I mean you can define quality however you want. A lot of people define it differently, and that makes it more difficult. It's hard for one, tell a member, hey, Mike, your provider's not that good. It's not great. It's not great. It's not easy. You have to talk about the details in order for them to accept it. They probably won't. But it's one of those things where maybe quality isn't as important, and with minutes, or it's not as important, but it's not as high of a priority, right? You just want to make sure you have a certain level, and that drives who you have. But one of the things about Minnesota is like they had people in lower tiers, and they were like, okay, we can offer you value-based payments, like with cost sharing to get into the higher tiers. And some tried it, and a lot of people, it ended up going away in the end. It's like a lot of providers were like, you know what? I don't want to deal with this. I want to get into the higher tier. I'll just get paid a little bit less to get into the higher tier. And so that's what ended up happening. And so I think that's another point for like, hey, maybe we just start setting rates of some sort, and providers are going to go, you know what, this is what I'm going to get. I don't want to lose the volume. That's what I'll take, and they'll be part of the network. And so I don't know. That's just kind of like one of the learnings from Minnesota that I took away. I don't think the quality didn't suffer overall. There is a study out there about the Minnesota health plan. State plan. It's been in place for quite a while. I was hoping Sarah Drake was going to be on. She's unfortunately has something else. She's actually a card carrying member of the plan, so she has real life experience in it. So, but in any case, it's like those sorts of like learnings that we can have from these situations, and hopefully, I think we're all kind of leaning, maybe at least you, me, and James, we're all leaning in the same area. I don't know if other board members, IWG members, have thoughts about this, or like concerns around what some of the ideas we're tossing about for now. But yeah, so I don't know. We just like Minnesota's. This is one way of doing it. It is a little bit it is bigger. You do have tiers. It's a little bit more complicated to understand, but it is kind of like a variant on what you do for Garner, except its cost sharing is on the front end rather than on the back end in this case. And then Sean, you brought up Tennessee, which is 2 slides, I think, from here. This is more of a reform quality-based thing where the episodes of care, you do have episodes of care, and they looked at is a gradual implementation as they go from some of the easier ones. I think, James, they started out with essentially like knees, right, or something like some of those standard COE episodes.
Yeah, I think maternity was early. Maybe diabetes and knees. They did waves of episodes. I think the first one was 5. Maybe they were all 5 different episodes. And I haven't checked in the last year, but they were up to 5, 6 waves with significant more episodes and more dollars covered. It is more of a regulatory approach. It's all transparent or not visible, I should say. It's not asking the member to do much. The episode is assigned to a quarterback who's in charge of the entire quality and cost dimension, and then those quarterbacks are ranked, and if you are commendable or the best, you get a little bit of money bonus, and if you are acceptable, everything's normal, and if you are below acceptable, they claw back some money from the providers. I think both Tennessee and Minnesota are examples where there is a lot of collaboration, meetings, work groups, advisory panels. I think there is a lot of superstructure around this type of reform compared to 1067, pass a law and then, let everybody dance around trying to meet the new requirements. I do think that it's encouraging that Minnesota and Colorado especially, there is a preconceived mechanism whereby people can lower their rates. And they can become the preferred tier, they can become a green light provider. And I think that that's almost as good as saying, sorry, this is all the money I have. This is all the money I have is kind of an absolute. And do you want to look good in the lineup is a little weaker, but still powerful.
James, do you think that this model, the Tennessee model, could piggyback off of, the Oregon's patient-centered primary care homes as some kind of mechanism by which to figure out who's the quarterback?
I'd like to think more about that, but I think the quarterback identification, like these episode-based programs, they do have a pretty linear logic to decide who the quarterback is based on the percent of charges for the total case or something. It's not always the primary care provider. So I guess I think components of the 10, I like components of all these programs as something that would give us a way to come at it from the bottom a little bit more, give up a little bit on huge blanket policy reforms that are challenging given our 8% and the sort of limited number of powerful health systems and the carriers that, that we've got to work with that are dependent on these few powerful health systems to put their networks together. So I guess I think, not answering your question very well, specifically with the primary care home program, I think it's a great idea, but I can't see it exactly right now. And I do think that given our constraints, if this is something that PEB and OEB are going to do, having a supportive carrier sort of sponsor for these kinds of ideas where we try to find stuff that seems really stupid and egregiously high priced and correct it. Even that, which sounds so obvious, will not be easy because those things that are stupid are well indoctrinated in the payment systems, and all of those inequities that we find and the 2 and 3 multiples of cost, those are all flowing up to a total line item that entities need to run their businesses. So I guess I think my thoughts shaped by trying to get this presentation together and the last few years goes to what we've been talking about. A variation on reference-based pricing, using the concept of the episode so that, the quarterback who uses the ambulatory surgical center might be looking a lot more favorable than the quarterback who uses the outpatient hospital, and, try to roll some of the site-related payment into the episode-related analysis, and then just try to find a way that it doesn't end up being too much pain on the member, like an upside benefit, maybe a little bit of, choices that cause them to invest a little more thought in their healthcare without making them feel like they're getting hammered.
So Sean, I was just thinking, if you wanted to kind of get more of a, connection with like other state, reforms or, with that primary care medical home, patient-centered primary care medical homes, it could kind of do something with with Minnesota in terms of maybe tiering the PCPCHs based on total cost of care, right? I mean, because they're the kind of the quarterback for the overall members' health, right? And that's what the coordinated care models are trying to do, right? You're kind of having them kind of be the quarterback of the entire care. Each episode might have a separate quarterback in terms of the surgeon, but the total cost of care of a member would be essentially tied to the primary care provider. And so determining total cost of care there, and I don't know what other quality elements you want to add in, but at least for the cost and being efficient about usage of services there might be one way to do it. I mean, I've had a provider here in Bend that I thought, is a primary care medical home. They ended up giving me a lab service that wasn't covered because it's just like too expensive. It's like cholesterol lab service that was too expensive. I'm just like, why are you choosing that? That's just not efficient. Just get the regular cholesterol lab, and so that's kind of like trying to get that unnecessary usage out of the system. I think, you might be able to define it based on the quality, on the total cost of care, assuming, the data with APAC and everything else and whatever other data that OHA has. You might be able to get something around that to kind of bring it together, and you have an idea of like which providers are maybe the most efficient, and then use that to help segment or, incentivize usage of those providers or create network around it. So just tossing that out there.
Also, just drawing everyone's attention to the chat. I think Sally had a few good points, so just making sure people see it.
Yeah, I don't know. It's yeah. I think it might incentivize them. James, I don't know. I mean, I kind of feel like the negative publicity is probably actually a bigger driver, unfortunately. If you're in a lower tier, getting notified you're in that lower tier, they're more likely to make change, save money. I don't know. Unfortunately, negative publicity isn't good publicity in this case. But yeah, your general point, I think, still stands, Sally, at least for me.
I mean, if I was the provider and I was on there and I wasn't looking so great, I'd be like, well, that's embarrassing, like I gotta up my game. So, potentially, I don't know. But
yeah,
I might work a little harder to be a little bit better so that it didn't feel as embarrassing,
Yeah. And with the COEs, I think we started running into issues where it's like, again, with the quality, it's like, no, we're not defining quality that way. We're defining it a different way. And so you get into that fight. It's just much easier with cost, right? It's like, okay, no, you're charging this much versus this other provider is charging this much. And that's much more black and white in this case, like more obvious. And so I don't know. It doesn't help triple aim as much, but it is easier and a little bit more accepted. So
I liked our discussion here where we were talking about the point of the quality thing. It's not that quality is not important, it's that it's really difficult to measure. And so I like the idea that we were saying that was coming out, where it's really just kind of a basic threshold, like to sort of like get the bottom, very obvious 10% bottom off, where that's just clear. When you start getting into like beyond that, there's just too many like, well, this person accepts more high risk patients and this person that, and so on, and it's an endless cycle of spinning. And I feel like we don't want to get into that kind of spinning game again. It's just like a basic threshold, and then it's just all price. um I don't know, I kind of like that idea. I like several of the ideas that we've been talking about, or some combination of them. I like what James was selling on, trying to change the thinking about, that there are certain items or certain item-like events in healthcare that are sort of like a commodity. It's just like, this is what this is, and this is what it's called. That thinking that way, it's interesting. Um, yeah, I mean, some of these items are interesting. I agree I think Sally was saying this a little bit earlier in the chat, is like when you sort of make healthcare the problem of the patient, like they're the ones that need to solve the, multi-billion-dollar industry's problems by choosing whatever. That starts getting troubling, especially if it's not super clear how they do that. I think, yeah, that's not to say that they shouldn't have any involvement in any kind of decision making. I'm not saying that, but if it's interesting to think about how to adjust things kind of on the backside and also have some pretty obvious decision points the for members, sort of combining like that with that some of these models we're talking about. I don't know. There's a few things here to pursue, I think, maybe.
Yeah, I mean, like I said, being the benefits coordinator, I do all of the face-to-face interaction, right? I do the open enrollment, I get out to schools, I talk to people, I help them so that I'm the face to everybody, which means I also have that experience of, what are the barriers to what is already in place for people. One example of a million I could give you is I met one of our members at their work site last week and spent an hour with them, helping them find a primary care, helping them set up their MODA account, helping them set up their Garner account, doing all of that. That all the employee is not computer savvy. In fact, when I offered to help them, they got tears in their eyes. Like for some people, even those steps are really overwhelming, right? But not every entity and not every employee has somebody that can do that work, right? To sit with you. And so, and that's not unique. I do this all of the time. Like during open enrollment, we have open enrollment computer help sessions, and then I go to our transportation department multiple times during open enrollment. The demographic of our transportation department is majority retirees, right? Like this is not the world that they live in, right? They're, these systems are not comfortable or familiar to them. And so, I will always give a pause to, like you said, adding another layer of work that the member has to do in order to get access to that quality or affordable care. Because I see it every day that what already exists feels overwhelming enough to some to where they they kind of throw up their hands, right? And so they're not getting that access to those things.
Yeah, definitely. I mean, yeah. I mean, we definitely want to keep those thoughts, those considerations. I mean, it is, we are asking a lot. Healthcare is difficult to understand. And, what can we do to make it easier, right? What's the best way of doing it? And we're having those discussions. Maybe Maya, because we are basically out of time. Can you go to the next steps page? There is some other information, and hopefully the four slides that we kind of skipped over might help you think about some of these ideas a little bit. But so we will have additional discussion in March. I think we'll take back a lot of the conversations, have some stuff internally, discuss it, and start to come up with ideas. And as you're spending the next, I don't know, few months or the holiday season, and you're just done unwrapping presents or whatnot, as you're thinking about it, if there's something that comes to your mind, definitely think about it, bring it back to us, and we'll take it as ideas, and we'll try to synthesize something for us in March to kind of carry on this conversation. So I don't know, Margaret, if there's anything else you want to add on that, but if not, I can turn it over to
No,
Sherry.
yeah, I think that closes it. And just to note, we do have a January meeting. So the next work group meeting will be Wednesday, January 28th. So materials and agenda will come out in advance of that. We certainly look forward to continuing some discussion. Kimberly, not to steal your thunder, but to my knowledge, I don't believe we have any public comment.
Okay, good.
So
we do not. I
yes.
checked.
Okay.
Yeah.
Great, thank you, Ali. So yeah, just to take care of that on the agenda.
Perfect. And so what a incredible, like, I mean, we just have so much work to do, don't we? I mean, it's just, I mean, to make a difference. It is just, this is huge, this is about money, y'all. This is a big deal. So, and everybody that you impact, it's a big deal. So, and our members are our number one priority, always our number one priority. So thank you all so very much for being here. Did anybody have anything for the good of the order? I want to make sure that everybody is heard. Sally, wonderful addition to our team. Thank you so much. You just bring up some good stuff. And Sean, we love that you just ask the questions. So everybody, please have a good holiday. Merry Christmas, Happy Hanukkah, all those great things. And everybody be safe, and we will see you in January. Thank you.
So much.
Meeting adjourned. And
Thanks,
Mercer,
everyone.
thank you.
Thanks.